आय शुड कॉंग्रॅच्युलेट यू ऑल. बाकी सगळीकडे क्लिनिकल मीटिंग बंद व्हायला लागलेत. फिजिकल तर पूर्णपणे बंद आणि ऑनलाईन पण असं म्हणजे
वैशाली, we are
अटेंडन्स
live.
कमी आहे. ओ वंडरफुल.
मॅडम एक आता जस्ट
Ma'am, please
Start.
start. Ma'am,
Start.
please start. We are live. Thank you.
No, please start.
Today, Dr. Vaishali More, madam, will present interesting cases in pediatric nephrology. Dr. Vaishali More, madam, completed her MBBS, MD, DNB from said GS Medical College, KM, Mumbai from Pune. She completed DCS from same GS Medical College and done fellowship in pediatric nephrology from Wadia Hospital, Mumbai, and the same fellowship in pediatric nephrology from National University Hospital, Singapore. Madam attached to multiple hospitals in the Mumbai, like Tara Hospital. In our area, madam is attached to Ankur Hospital, Joshi Hospital, going Vikas Children Hospital. Madam has multiple national and international publications, 28 international publications, and paper presentations at various conferences. Please, I will like to ask Dr. Vaishali More madam to start her interesting cases.
Thank you so much for the opportunity to speak and for the introduction that you have given. I am sharing the slides. I hope you can see them. So please let me know if you can see them. Can you see the presentation?
Yes, ma'am.
Yes, ma'am.
Yes.
Okay, so I'm going to the
Please
presentation
make it full
mode now.
screen.
Yeah.
Yes, it's full screen.
Can you see that now?
Yes, ma'am.
Yeah. So if you have any problem with the audio, then let me know. I will switch off my video. Okay. This is a single case. These are not multiple cases. And this is how a lifestyle choice can induce kidney injury. So let us look at the case first. This was a 15-year-old boy who was brought by the mother. He was self-diagnosed as proteinuria by the mother. He had a urine microalbumin of more than 380, and the cutoff is it should be less than 30. So it was quite alarming for her. In addition to that, she had done a lot of other investigations on her own. Hemoglobin was 14.8, total count was 4,800 with 45% neutrophils and 45% lymphocytes with a platelet of 2.6. The fasting glucose was 82, HbA1c was 5.5. Another alarming report was that the serum creatinine was 1. The urine protein creatinine ratio was 1 and the serum creatinine was 0.8 or 0.9. The urine routine specific gravity showed 1.025. Protein was 2 plus. The rest of it was normal. There were no abnormal cells or cast or anything. Vitamin D was 22. Uric acid was elevated. As you can see, the patient's height was 164 centimeters, weight was 76 kg, and but blood pressure was within normal limits. So I asked for an ultrasound kidney ureter bladder. It showed the kidney sizes were normal. The echogenicity was normal for the sizes were normal for his age and height and sex. The child is also on Inspiral now since 1 month because he is a known case of ADHD. But when he came to me, he was not on any medication. It has been started only since the last 1 month. There was no history suggestive of any kidney disease or urinary tract infection for the elevated creatinine as well as the elevated protein creatinine ratio and the uric acid. So while delving into more into history, there was a history of high protein intake, and he was doing daily weight training and 2 days per week of karate. His breakfast was 4 eggs, bacon, and protein powder. Lunch was chicken or fish or red meat. Again, dinner the same thing. Milk once a day. Half a roti if he had, he would. Otherwise, he would have occasionally quinoa khichdi, but there were no fruits and no vegetables in the diet. And thus, the entire intake was protein, more so of animal protein than any plant protein. And in that too, there was exclusive protein intake. The water intake of this child was less than 1 liter, though he was not able to tell exactly how much he is drinking, but it was clearly not adequate. So what we decided was that we will take a dietitian reference to evaluate his diet as to exactly how much amount of protein is consuming, and to change accordingly. I asked him to reduce the gym and karate. And instead of that, on the days when he was not going to the gym, he should take a walk of 45 minutes or so per day. I asked them to replace the animal protein with plant-based protein. At least 50% of the intake should be that. And the mother then came out. She found it alarming that it is the diet which is, kind of causing all this problem. Then she came out with reports of her 19-year-old child. 19-year-old clearly could not be seen in a pediatric hospital. He had a urine protein which was 1.2. His serum creat was 1.4. His uric acid was also on the higher side. He was also taking a similar animal protein based diet, and all this was to lose weight and gain muscle, etc., etc. So I advised him to see an adult nephrologist. Then the patient was lost to follow on telephonic inquiry on multiple times after trying to, on multiple attempts. Finally, I could get back to them. They have added, the mother has added vegetables in the meals, in each meal, but the same protein intake continues. And the gym they have decreased to alternate days, means he is doing cardio in the gym itself, followed on alternate days, he is doing the exercises, that is weight training. They did not see a dietitian. They have repeated the test. The urine protein creat has dropped down. She has done protein creat now and it is 0.04. The uric acid is 7.5, which is still on the higher side, clearly because he's still having a lot of non-vegetarian protein. And the serum creat has dropped from 0.9 to 0.64. According to mother, they consulted an adult nephrologist. A similar change was advised by them for the elder sibling, and he is also doing well. She has done his blood and urine test. So the problem is that what is trending now is fitness, a six-pack ab, both in men as well as in women. Everybody wants to look very good for aesthetic purpose, and this is the problem which we are actually facing. That this is a publication from the Lancet, and we are facing an obesity challenge now. In 2021, 43.4% of the population was overweight or obese. It has clearly increased till 2025. And by 2050, it is expected that 70 million children will be either overweight or obese. And of that, we will be dealing with 39.6 million children who are from 5 to 14 years of age. So there are multiple problems here. There is peer pressure, there is social pressure, and if you meet anybody, before they ask you how are you, the first thing they will say is you have grown fat or you have become thin. And in multiple cultures, it is considered to be rude to kind of comment. But in our culture, somehow it is taken as a routine. I think we should bring about a change there, because we are probably making these kids more conscious about their their kind of weight or looks. This leads to low self-esteem, which we can teach them to deal with it with achievements, and looking at their achievements and being grateful for whatever is there. And the third thing is that it causes depression, for which of course therapy is the way out. If you look at the food, wellness and fitness industry, it is worth 6.5 billion US dollars in India, of which 2.6 billion US dollars are just gyms and slimming centers. In addition to that, there is food, apparel required, equipment required, etc. And there are 2 million social influencers who are there on the internet free of cost at the click of your mobile app, who are available to you to give you free advice. And hence it is very important to make informed choices. So what does literature say about this? So there are multiple articles that you will come across on the internet. Some of these are genuine, some of them are sponsored, and so it is very difficult to kind of make out what exactly who is trying to say. So if we look at animal studies, or we look at articles which are studying, kind of our meta analysis, we come across what I will be telling you soon. So what does exactly high protein diet do to the kidney? So the estimated requirement average for almost 98% to 99% population is 0.83 grams per kg per day. There is no consensus as to what is a high protein diet, but if it is more than 1.5 grams, most of the articles consider it to be high protein diet. And what does high protein diet do to the kidney? It increases the blood flow to the kidney. This causes an increase in the GFR and hyperfiltration. And because of hyperfiltration, damage starts. If there is underlying kidney disease, then there is more likelihood of damage. But if there is no underlying disease also, like in this particular child, there can be damage. So we have to be aware of that. And how does it present? It will present with albuminuria or proteinuria. So what is the mechanism behind this? So it is postulated that high protein intake increases the dilatation, the vasodilatation of the afferent arteriole. This increase in vasodilatation causes increase in the intraglomerular pressure, which causes increase in the GFR. In addition to this, there is increase in the volume and the weight of the kidneys, as well as expansion of the mesangial matrix, and there is interstitial fibrosis also. This happens because of increased nitrogenous waste products, which are coming from the excess in the protein that is ingested, and also because of endocrine mediators like glucagon and IGF-1. This is exactly what happens. So high protein intake, dilated afferent arterioles, increased intraglomerular pressure, damage to structures, loss of more nephrons over a period of time. Then again, so it is like a vicious cycle which is going on. In addition to this, if there are concurrent CKD risk factors, then the damage will be much more. So what are the other factors which are affecting your, as we said, nitrogenous products, so high blood urea nitrogen, high load of acid which comes from animal protein mainly, so metabolic acidosis, ammonia genesis occurs which causes damage, and high dietary phosphorus also, which causes increase in FGF23, which in turn can cause vascular calcification. So animal versus plant protein, if we look at, then animal protein causes more damage because it causes hypertension, it causes an imbalance in the gut microbiome. There is more ammonia and sulfur which is released by animal protein products, and more oxidative stress and inflammatory markers are there. So what are the short-term and the long-term effects? So in the short term, it will increase the urine protein excretion. It will elevate the creatinine and increase the GFR. In the long term, it will decrease the GFR, but that is because the kidney function is deteriorating, not decrease GFR in the good way. There can be CKD, and this is seen more again with animal protein. So what are the recommendations? In a patient who has a normal kidney function, that is, a GFR is good and there is no proteinuria, but is at risk for CKD, like example, diabetic, hypertension, children with solitary kidney, or children who have other problems like vesico-ureteric reflux, or they have had any surgery for the kidney, or they have had urinary tract infections and are likely to have scars in the kidney. The protein intake should be less than 1 gram per kg per day, and it should be plant-based protein. Of course, with higher levels of CKD and the requirement, depending upon whether the child is being dialyzed or not, the requirements are different. So the kidney disease improving global outcome, or KDIGO guidelines of chronic kidney disease, they suggest that 0.8 gram per kg should be given to adults where we are having one of these problems. That is, there is some degree of chronic kidney disease, and they should avoid high protein intake. In adults who are able to and are willing and are willing to, kind of take the risk, then they can be, but it has to be under very close supervision, which we will not advise in our patients because follow-up is not really very reliable, even from well-to-do families. And in children, they say do not restrict the protein because they are growing. But at the same time, we have to look into this, whether there is an underlying disease or no disease. So to summarize, I would say that before any patient, like your kids are now, who have been following up with you for the last 15, 20 years, they are now in the age group where they want to, kind of do gyms and start exercise. And the gym instructor inevitably prescribes a protein powder and tells them to eat 16 eggs per day, etc., etc. So before starting gym and this diet of high protein, they should consult a doctor. We should take their blood pressure, a basic renal function, ultrasound, kidney, ureter, bladder, and a urine routine should be done. This will give us an idea as to whether it is a normal kidney or not. And if we have any patient who we know we are following up for solitary kidney, etc., then in those kids we have to be extremely careful. We will not give them a diet which is more than 1 gram per kg per day. The protein, if we look at it, then the analysis shows that if the daily intake is 1.2 gram, then there is a twofold faster annual kidney function deterioration that is seen. So compared to if it is less than 0.8. So as far as possible, we should try and be somewhere in between, preferably to 1 gram per kg per day. In addition to that, water and fiber intake also are absolutely important, and it is worthwhile if we have a renal dietitian who is kind of involved, so that she can tailor make a plan according to the child's weight requirement and needs. So in addition to what I already said, as I said, solitary kidney or any CACUT, then do not consider putting them on high protein diets, or consider giving them a gym and a very high weight training, etc. Any other underlying kidney disease also the same thing, like our nephrotics, sometimes they want to join gyms and they want to do gymnastics, especially if they find that they are short after being on steroids for a long time. And patients who are having comorbidities like hypertension and diabetes mellitus. So I think that is all. It is a short case, and if there are any questions, then I will answer them. But it is only one case and a short case.
I have a question, Vaishali.
Yes, ma'am.
Yeah, I want to ask, why did the mother choose to do those tests?
She decided just like that. No reason, no particular reason. I think she is an IIT engineer herself. She's associated with IITB. So it becomes very difficult to treat people who will, kind of go on Google and chat GPT and get answers for their own questions. So she has chosen to do the test, probably because she read somewhere that it is wrong for kids. And she herself came out that they are eating a lot of animal protein, and she told me point blank as to what all they are eating. Usually I find mothers covering up a lot. They never say that the child is doing anything wrong. If you ask how much water, they'll say "Khub pani pito." There is no mother who will say so. The child may effectively be taking 1 glass of water and drinking 1 or 2 sips and throwing it away, but the mother's impression is that
Try
he
to
is
cover
drinking
up.
a lot of.
So important. Some of our kids also take so much protein, and
Yeah.
it always bothers us.
Yeah. So there is a pediatrician from down south, Shivarama Mani, I think, if I'm right. So she does make videos online and puts on Instagram. And surprisingly, 2 3 days back, somewhere in the last week, after last Wednesday only, she has put a video saying a lot of youngsters are coming with creatinine of 1 and 1.2, and all of them are having a lot of high protein diet to lose weight. And there is no evidence that a high protein gives you satiety, but there is no evidence that our traditional carbohydrate that we are taking is not good for health. But this is a misconcept that has come up, that remove all the carbs from your diet and eat only protein, and that will
Proteins.
help you lose weight, and it will help you kind of gain muscle. So what happens is they are not actually working out that much, they are working out less. and the protein requirement that they are getting may not be at, kind of balancing, and at the same time there is less water intake, there is less fiber intake, and that is how the entire process is affecting them.
Correct. Thank you
Uh,
so much.
yeah,
Yeah.
Vaishali,
Yes, ma'am.
all of these fever medicines containing mefenamic acid, ibuprofen, they are also nephrotoxic.
Yes, ma'am. All of them.
So we should
Mefenamic
avoid them.
acid as far as possible. Mefenamic acid I find what shall I say, aggressive, or more harmful as compared to
Ibuprofen.
ibuprosic. Both are bad, but mefenamic acid, more patients are coming with side effects of that. Many a times they come only with microscopic hematuria and nothing else, and it takes time for the microscopic hematuria also to go. So
Mm.
it stays for quite some time. If at all, I would suggest that if at all you have to prescribe, and you know that the parents are good at follow up with you, and it is a known patient for you, then in that case, it is important that you write that for this particular episode you can take it, not forever. What happens is our parents, they start self medication when they want, as they want. Every time the child gets fever, they will give that medicine, they will give it to other kids also. That is the problem. So when you have assessed the child, you know that the hydration status is good, and you want to give mefenamic acid, those 1 or 2 doses in that particular episode is all right. But otherwise, I have seen people giving it round the clock, 4 times a day. The fever has gone away, and after that the child has come with hemolytic anemia plus renal failure requiring dialysis. Dialyzed 4 days, for 4 days in Goa, then dialyzed here for 3 4 days, and we find that it is all related to mefenamic acid. So more than one side effect can happen in one child. So as
Better
far
to
as
avoid
possible,
it.
avoid. As far as possible, avoid. If we cannot avoid, then in that case, see to it that you write it only for that particular episode, because next time the child may be having fever, and in fever he may be dehydrated, he may be having loose motions and vomiting, his intravascular volume is low, and he wants to take mefenamic acid, so then it creates a bigger problem.
A lot of our children also develop interstitial nephritis
Yes, they do.
because
They
of,
do.
yeah, because, yeah.
This particular child I'm talking about was interstitial nephritis only. The one I was telling you just now had both renal failure and this also, hemolytic anemia also, and he was referred as a suspected case of hemolytic uremic syndrome.
Okay. Thank you, ma'am. Thank you so
Thank you,
much.
ma'am. Thank you.
Thank you, madam.
Thank you, everyone.
Thank you very much. Nice presentation, madam. And it is eye opener for us that nephrotoxic drug. And I think high protein diet is also act as a nephrotoxic drug nowadays. And it is a
Yes, it
very
is.
uh, fad now in younger generation. Thank you, madam. Now our next speaker is Dr. Alka Jadhav, madam. Hello, madam. Madam is there. I would like to ask. Hello.
Dr. Alka Zada was supposed to join. She has given us slides and we have give it to Dr. Pallavi because she was on a
Yes,
traveling. She has joined. She's there.
yes,
Alka
sir.
is there. Alka, you're there. Yeah, her slides are also there. She's there.
Okay. And Dr. Alka Jadhav, madam is additional professional of pediatrics, PJMS, Navi Mumbai. She was a former professor and in charge division of pediatric gastroenterology and nutrition at Sion Hospital. ORS week coordinator for MBIAP 2001 to 2019. I have only brief description about madam. Uh, I would like to ask Dr. Alka Dada madam to join and start her presentation.
Okay, ma'am. We cannot. You are not audible, ma'am. मनोहर सर तुम्हाला आवाज येतोय?
हा तुमचा येतोय मॅडम, पण मॅडमचा नाही
नाही
येतो मॅडम.
नाही नाही, अलकाचा येत नाही.
हा मॅडम
Okay.
लेफ्ट झाला मॅडम.
Yes, she will join again, I think.
हा त्यांचं काहीतरी याच्यामध्ये प्रॉब्लेम असणार जॉईनिंग मध्ये.
Okay, okay. We'll wait.
In the meantime, I want to say that we are seeing lots of viral infections, lots of respiratory viral infections, cough, cold. I think we have isolated by PCR influenza A and also respiratory syncytial virus,
ओके, RSV.
Okay.
RSV.
Because
Anyone
here
else?
here also people are saying that there are a lot of viral infections and they are not getting anything specific. So it must be the same thing. What it can't be different from what
We also got influenza A.
Yes.
बायोफायर मध्ये ना.
No,
Hi.
we are doing flu NGS.
flu.
NGS. There is a
NGS.
company,
Okay.
yeah. So
Which company is doing it, ma'am?
Haystack Analytics. I can share the number with you
Yeah,
if
yeah.
you want, Vaishali. Yeah.
Sure.
म्हणजे
Let's
कोण
Yeah.
all that doing.
इट इज थ्रोट स्वॅब, नेझल स्वॅब त्याच्यावर करतात
Throat
की
swab, throat nasal swab. Yes.
Yes.
Alka has joined. I think we can start.
Yeah.
Hello,
Yeah.
Alka ma'am.
Hello.
Hi, it's nice, Vaishali. I was listening to you after a
Okay.
long time.
Welcome, madam. Welcome.
Welcome.
Welcome, Alka,
Actually,
madam.
yes.
Good
It's a
afternoon, madam.
long expedition, you know. I wanted to come tomorrow, but today I thought I'll come back, and it was difficult to travel. Anyway, difficult situations we need to manage. Okay. So what I feel is I'll speak from my phone. Some or the other, God knows, something has happened to my Zoom setting. So can somebody project the slides?
Yes, madam.
Is that okay, ma'am? Yeah.
Pallavi
Yes.
has got the slides. Yeah.
Yeah, I can see the slide, and then now I can actually probably. Pallavi has been doing, thank you, Pallavi. You have been doing it all the time during my speech.
Most welcome, ma'am. Please go ahead. Thank you.
Yeah. See, now actually, if when really goes, next slide. See, all of us are aware 29 July has been celebrated as World ORS Day. And actually, IAP Mumbai has been celebrating the ORS from 2001 till date. And now recently they have shifted to fortnight ORS week. Formerly, we used to have the World ORS Day with 1 day celebration, but to create awareness, we have been doing it. Next. So this ORS Day, this year's ORS week is from 25th to 31st July. The slogan for this year is ORS, a simple solution for healthier future. Sip smart, stay strong, and say yes to ORS. This is the IAP slogan, and we have been practicing it for, of course, last 25 years, but every year the slogan gives a new insight to the same problem. Okay, next. So, as you are aware, diarrhea is still. Can you hear me?
Yes, ma'am. You are audible. You are audible. You are audible.
Diarrhea is the second commonest illness in a day-to-day practice. And actually, it is considered as a bread and butter of pediatrics. ORS and zinc, they form the backbone of diarrhea treatment. Everyone is familiar with plan A, plan B, and plan C of diarrhea treatment. I'm not going to tell you anything new. And we have rotavirus, which has reduced the diarrhea related prevalence of diarrhea almost by 50%. The role of antibiotics and antiemetics is limited, and 5% of the children with acute diarrheal disorders will create a challenging situation. Here we are going to have today we are going to discuss maybe one or two of these situations. Okay. So now we go to the next slide. We have seen one 3-month-old child, Shabana, who was a top-fed baby, who with cow's milk diluted with mother was using bottle and she was breastfeeding, plus she was using intermittently bottle feeding, means every day she was not using the bottle, but when she would go out she was using the bottle, otherwise she was feeding with vati spoon. So she was partially respondent to what we have informed. She was a good birth weight baby with 3.1 kilos. Present weight was around 3.9 kilos. She came with vomiting 6 to 8 episodes per day since last 3 days. Vomiting was non-projectile, non-bilious, not associated with any blood, only ingested food particle. The loose motions were watery, large volume, greenish, associated with shreds of mucus, no blood, 6 to 8 times a day, especially more after feeding since last 2 days. There was no history of fever, no abdominal distension. Next, next slide. Child was passing urine in the diaper, but mother was not knowing properly how many times, which is a very very common situation with watery diarrhea. The associated infections, child never had any respiratory, child never complained of any respiratory tract infection, no otorrhea. There was no refusal to feed, child was feeding well. Child had taken a rotavirus vaccine, the second dose, 15 days back, and mother had noticed some perianal redness for last 1 day. Mother was giving mixed feeding because she was initially breastfeeding, but last 1 month she has started using top milk diluted in cow's milk with sugar added. There is no other significant history in this case. Next. Don't you think this is a very, very common scenario? You must be wondering what is so different about it. This is a common scenario. Everybody is facing this actually. So this child was on examination. The child was lethargic. He was having signs of some dehydration in the form of sunken eyes, sunken fontanelle. The skin pinch on the abdomen would go back slowly. The tongue was dry. On examination, the vitals, the temperature, the pulse, and the respiration was normal, though the pulse was on the higher side. SpO2 was 95. The blood pressure was appropriate for his age. There was no hypotension. The detailed anthropometry revealed the weight of 3.9 kilos with weight for age less than minus 3 Z score, indicating that child was severely underweight. The length was 50 centimeters, which was also saying that the child was stunted. It was less than minus 3 Z score. But the weight for height was normal. This child was not what we can say is infantile SAM. Or this child, though he was failure to thrive, he was underweight and stunted, but he was not SAM, severe acute malnutrition. Okay, next slide. Other examination revealed there was a perianal redness, excoriation extending up to the lower buttock. There was some palmar pallor was there. Per abdomen, there was no distension. Child had soft abdomen, no hepatosplenomegaly. Other system examination, CVS, RS, CNS, normal. Another thing was child when offered foods or fluids, the child was drinking very vigorously, suggesting that this child was having acute gastroenteritis with some dehydration. In a child who has severe undernutrition with some palmar pallor, and to rule out whenever we have a lactose, we need to rule out lactose intolerance. The contributing factors are bottle feeding and cow's milk administration. In if the diarrhea would have been prolonged, probably we need to consider cow's milk protein allergy if diarrhea, because there was a recent introduction of cow's milk. So it is actually the multifactorial. So we have to come to one by one with elimination. This is 80 to 90% of these diarrheas. The situations are similar. So you will wonder what is so different or difficult to manage. Only thing is, this is an infant who has come, who's severely underweight, who has come with diarrhea, with some dehydration, who is on mixed feeding. So let's see how I feel we should manage. So of course, the opinion of the house is most welcome. Next. So what investigations probably are minimum required? They are complete blood count with C-reactive protein, especially because the child is less than 6 months. We would definitely like to know the what is the hemoglobin, the total count, what is the C-reactive protein, stool pH and reducing substances. We can do it bedside also if we use the litmus paper and Benedict's test to do the reducing substances. Then other optional investigations are stool routine microscopy and culture. They are optional. We really do it if they do not respond to primary line of treatment or the diarrhea becomes persistent or prolonged. Otherwise, routinely stool routine microscopy, routine rotavirus antigen detection test, which is not indicated. Serum electrolytes and RFT, that too also if the child does not respond within 24 hours, or if the child has some clinical signs of say hypernatremic dehydration, then only. Otherwise all diarrhea cases, routinely we do not advocate doing serum electrolytes. So because the child is small, we would like to do CBC CRP, and in presence of perianal excoriation we would like to do the pH reducing substances. Of course, the corporate practices are different. Maybe if I would have been in a corporate setup, I would do all these investigations. But at present, I personally feel these minimum investigations are justified. Next. So now what treatment is, since the child is small, it is better to admit or observe in a daycare for 2 to 3 days. We child is severely underweight. So irrespective of whether CRP is positive or negative, it has been shown that severely underweight, as well as a child with severe acute malnutrition, they do better if we give them 1 week of antibiotics, at least 7 to 10 days of antibiotics in presence of infection. So we are going to give antibiotics only because child is underweight. Okay, so we will start on third generation cephalosporin, either either oral or either oral or injectable. We will give the antibiotic depending on the condition. Then we will start the child on plan B of the standard WHO ORS. What is standard WHO ORS? Is actually the classical WHO ORS, which is 90 milliequivalents of sodium. Now again, now it has come down to, formerly it was called as low osmolarity ORS, and now it has become a standard WHO ORS because the classical has become a historical WHO ORS. So this standard WHO ORS, we will start with plan B. We give it over a period of 4 hours. We'll definitely, but we continue breastfeeding along with ORS, because after 2 ORS feeds, we would definitely like to give one breastfeed to prevent hypoglycemia. We'll give zinc supplementation 2 milligram per kg per day or 10 milligram once a day because the child is less than 6 months for a period of 14 days. That will prevent the further recurrence of diarrheal episode. Okay, next. Next, plan B. So, what is plan B in this child? So, plan B, how do we give? It is 75 ml per kg of ORS to be given over 4 hours. Give small frequent sips of ORS. If 10 minutes and then restart ORS very slowly. By and large, we do not give antiemetics unless the child is really profusely vomiting. But once we rule out meningitis, now we see ondansetron, which has been used, though it is recommended for persistent or profuse vomiting. Always a word of caution is rule out meningitis before you give antiemetics profusely because this you may miss out, and child may become drowsy because of dehydration as well as meningitis also. So use your clinical judgment before you use antiemetic. Okay, so continue breastfeeding along with ORS. Monitor the child one for the urine output strictly 1 hourly for 4 hours till we are giving that plan B. The what is the breastfeeding and ORS intake? And look at the sunken eyeballs and the skin turgor and the sensorium whether they have improved. So this plan B, by and large, with one cycle of plan B, usually the children from some dehydration they improve and become no dehydration, and then they go to plan A, where whenever the child vomits or has loose motions, we give half a vati or 1 vati of ORS depending on the weight and age of the child. Okay, next. Uh, no, there is, so after, no, no, 1 minute before that. Before this, acha, one slide got omitted. I'll just read out that slide because I'm sitting with it. After 4 hours, actually you reassess the hydration status of the child. If the hydration is improved, obviously, as you say, you switch to plan A. But if the hydration is worsened or the small baby, you do not know that child is becoming more dehydrated, urine output is dropping down, the sensorium is becoming more drowsy, it is better to shift to injectable fluids, that is intravenous fluids. We start with ringer lactate or normal saline. What popularly we give is a 30-70 drip, but for children who are less than 6 months, we give 30 cc per kg of full strength ringer lactate over 1 hour, followed by 70 ml per kg of full strength ringer lactate over 5 hours. Start oral rehydration solution around 5 ml per kg at the end of 1 hour when the first 30 cc per kg of drip is over. By then, you start giving them ORS along with the IV. If at the end of this 6 hours of 30-70 drip, the child is the same, you continue 6 more hours of plan C. But if the child is better, from plan C, he again comes back to plan B with more strict and rigorous monitoring, especially of sensorium, the breathing, the and urine output. These three things we need to monitor. And after that, maybe after with 2 cycles or after 30-70 drip, you still sensorium is still not better, you should have a look at the serum electrolytes at this point of time. Okay, so this is about the management of diarrhea in a small child. Now we go to next slide. So we go to that, we need to counsel the mother. So the diarrhea is ultimately a illness because of a poor environment. So we have to counsel the mother regarding breastfeeding. We have to relactate the mother because she has already started on cow's milk. So relactation, if it is not feasible or possible or it is not acceptable by the mother, then instead of diluted cow's milk, we still need to suggest. I know maybe many people may not agree, but it is we have to use infant formula as per IAP guidelines rather than the cow's milk. Okay. So whey protein infant formula needs to be used. If the stool pH is acidic, reducing substances are 3 plus or more, the child is not tolerating your infant formula or the milk, he continues to purge. So temporarily for a short period, you may use low lactose or no lactose feeds, but you must continue breastfeeding even in that situation. Ask the mother to apply zinc oxide cream in the perianal area. So that makes the diagnosis as well as the treatment part of diarrhea in a severely underweight child who's less than 6 months. So, shall we take questions at the end? Hello?
Hello, you can continue,
Huh,
madam.
continue. Okay.
No
So
problem.
now
Yes, yes, you
we
can
go to
continue.
the second
But instead of
situation.
giving formula,
Yes.
instead of giving formula low lactose, can we prefer that rice,
He's just
rice
3 months.
and dal
I
rice?
agree. That's why he's
Uh-huh.
3 months old. So
Because
acceptance,
that
rice kanji is the only thing which we could give. Okay,
okay,
but
okay, madam.
acceptance from sago, rather then they will go to arrowroot kanji and other things. So that will have more detrimental effect. Because to start with rice moong dal
Okay,
paste at this point of time, he's just 3 month old. That's the reason why we said that infant formula. Otherwise, we would have said that early introduction of complementary feeding would have been appropriate for this child.
Alka
That's
ma'am,
the
I
reason
wanted to
why.
okay.
ask.
Yes, yes.
Alka ma'am, can I ask one question?
Yes, yes, of
Ma'am,
course.
previously, even in patients who are known lactose intolerant, breast milk
Hmm.
was considered to be given.
Yes,
That
yes.
was even now it is the same.
Same, same. That's why I said we continue breastfeeding
Correct.
because the absorption is not,
Relactation.
yeah. So till relactation is possible because this child is actually severely underweight, but he's not SAM. So we
Correct.
can't give F75 and F100. So
Okay.
we need to give improved feeding. And
Okay.
child is beyond the age where we can give Lactodex HMF sachets also. Is 3 months completed. And he is at a vulnerable age where we can't have the early introduction of complementary feeding.
Okay.
If
Ma'am,
he would
what
have
are
been,
I would like to know your formulas which you are giving for these children who are less than 4 years. What are the exact components? Is there anything which has low phosphorus?
uh, low phosphorus, actually, to tell you the truth, we have been using only Pronan and Lactogen 1. So I have not looked
They
at
are
the
high
phosphorus,
phosphorus. Okay.
high phosphorus. I
Yeah.
have not looked at the low phosphorus formula. Maybe I look at it, and because routinely we have not been prescribing the formula.
Yeah,
These
please
are such
look up if you
yeah,
can find anything because
yes,
we
yes,
pose
for
a
renal,
genuine problem for right now. I have a patient who is a posterior urethral valve, has undergone surgery. Creatinine at birth was 3, phosphorus 8. So these are kids where we require something with low potassium and low phosphorus. But those
okay,
formulas are not available in our country. There are formulas, but they are not available in our country. And what is available for renal supplementation, those are not to be used for kids less than 5 years of age. So EBM remains the only solution.
Yeah,
This
yeah.
child has a twin who is at home. The mother is with the twin, so it becomes difficult for her to express and get them, to drop the milk to the hospital. So these are the practical problems we are facing. In case you come to know about any of these, which can
Yes,
be,
yes.
yeah,
Sure,
please let
sure.
me know.
I'll
Thank you, ma'am.
definitely search for it.
Thank you, ma'am.
Okay. Yeah. Now we go to the second case. Second case, I'm not going to present. First case I thought would be like MD exam presentation. But second case, I'm going to discuss the problems because now I know all of you are post MD. So management of acute watery diarrhea in a SAM child. So SAM child is actual the severe acute malnutrition. Diarrhea is almost 4 to 5 times more commoner with them. They require special care because they have a high risk of dehydration. Dehydration either is overdiagnosed or goes unnoticed till he is severely dehydrated. Once you give him the fluids, they can't tolerate the overhydration well. Electrolyte imbalances are common. Sepsis easily sets in fast, and mortality, they are 9 times more vulnerable to the death. So this severe acute malnutrition causes lot of problems when they come with diarrhea, and what to feed them becomes a problem. So we have to assess the hydration status very, very carefully. Sunken eyes and skin turgor may be misleading. Use the clinical judgment like lethargy, reduced urine output, capillary refill time with great caution. So we need to really use the clinical judgment. Monitor the hydration status and weigh the child closely. Pre rehydration and post rehydration, weight is the only criteria which we can really use them. Next. So, rehydration strategy ABC. The plan A, plan B, plan C remains the same. If the child has no or some dehydration, the rehydration fluid which we use is Resomal. Resomal is rehydration solution for malnourished children. How do we give? How to make Resomal would be our next slides, but right now I am telling you how to give Resomal. So Resomal usually we give 5 to 10 ml per kg every 30 minutes. We start with 5 ml per kg every 30 minutes in first 2 hours, and then depending on the tolerance up to 10 hours we can give if the child continues to have vomiting or loose motion. Okay. After 2 Resomal feeds, it is better to give 1 F75 feed to prevent hypoglycemia. Okay. So 2 Resomal feeds of 5 ml per kg, 5 ml per kg, then 1 F75 feed as per the F75 lookup table. If F75 is not available, you can give rice moong dal paste or rava kheer or rice kheer, but you need to give it. Then if the child is unable to drink, then we give Resomal via nasogastric tube. The dosages are the same as above. But if the child has come to you in severe dehydration and is in shock, we need to give IV fluids. And what IV fluids we give them? Again, a full strength ringer lactate, but dose 15 ml per kg of full strength ringer lactate, we give it over 1 hour. If the need be, then only we need to repeat it as 15 ml. We don't give 30-70 drip. So we give 30 cc per kg over a period of 2 hours, not 1 and 5 hours. So we give half the dosages over 1 hour. So 15 ml per kg of full strength ringer lactate over 1 hour. Repeat only if it is needed as early as possible. If sensorium improves, child is better, start giving him Resomal. After 2 Resomal feeds, give 1 F75. If we are suspecting cholera, Then we give our standard WHO ORS or our routine WHO ORS with plan B of normal child. Okay. Next. So how to this table is actually showing you the comparison of Resomal versus standard WHO ORS. The standard WHO ORS contains sodium of 75, chloride of 60, potassium of 20, and citrate of 10 with glucose of 75 and osmolarity of 245 milliosmol. Whereas Resomal, in fact, is half the sodium, is around 45 sodium of 45, chloride of 33, potassium is 40, contains magnesium and zinc, citrate of 7, and glucose of 125 to prevent hypoglycemia as well as to cause facilitated diffusion of sodium. So the osmolarity of Resomal is definitely more than the osmolarity of standard WHO ORS. Okay, this point is to be noted. Next, so Resomal is low in sodium because the malnourished kidneys of malnourished children cannot excrete excessive sodium. High in potassium and glucose to address the common electrolyte imbalances associated with SAM. Magnesium and zinc as per the needs of a SAM child. Okay, next. So how do we make Resomal indigenously? This is my own creation in the sense my own thoughts which I have put together. I'm sure I'm open to suggestion, but I have checked the osmolarity and calculated. Okay, so what we are supposed to do is next. Take 1.5 liters of clean drinking water. To this, you add 1 packet of low osmolarity or standard WHO ORS, which is 75 of sodium. Okay, mix till the solution is fully dissolved. After that, you add all of us, we have the injection potassium chloride. So 2 ampules, 1 ampule is 10 ml. So add 2 ampules of 15% injection potassium chloride. And all of us, we have the 10% dextrose. So 100 ml of 10% dextrose. We do not add Maxulf and zinc. So mix thoroughly again, label and use within 24 hours. Discard after 24 hours, even if it is not used. Is it clear? I'm going to say 1.5 liter of drinking water, add 1 packet of ORS, 20 ml of injection pot chlor, and 100 cc of 10% dextrose. Next. So now, after the calculation of this indigenously prepared Resomal, if you really compare, it is closely matching. Sodium of 45, here it is 46. Chloride is 40. Potassium is 37. Citrate is 6.2. Citrate is 6.2 and glucose of 80. Because if we increase the glucose, the osmolarity increases. So probably, but this is acceptable. I feel that it should be. This is the nearest matching which I could find. I thought it's the easiest way of making Resomal in your clinic. So is it? Am I need to repeat it again or it's understood?
Understood.
Yeah. So next. So now the principles of management of SAM in a child who has.
Alka, can I ask a question?
Yes, yes.
Can we add Kesol syrup instead of pot chlor injection?
Yes, yes. I was trying to do that, but Kesol, which preparation, how much, means everybody will be having a different K-sol, K-light, K-mac, different K-sol preparations. And that's the reason why I have not added. I thought injection pot chlor is available in, and it is a constant thing.
Okay.
Because that's the only reason why I added injection dextrose and K-sol. Because
Okay.
that's the only reason.
Yeah.
Yeah. So then the principle of management is you confirm the diagnosis of SAM by doing the weight, the height, the calculate MUAC and confirm that it is SAM. Then you assess the hydration status, whether child has no dehydration, child has some dehydration or severe dehydration. Look at the amount of weight. If the previous weight is of the child is known, look at the weight loss, the urine output, and the increased thirst. If the child has increased thirst, he is probably in some dehydration. But if the child is lethargic and not accepting, he is in severe dehydration. So we really have to do it. So accordingly, we classify. Always try to do the appetite test either with the help of whatever food he was eating before. If his appetite is good, if he's drinking good, he's still in some dehydration. If he has lost appetite, then probably he is in severe dehydration. Then obviously as a part of SAM management, monitor hypothermia, hypoglycemia, sepsis, shock, anemia. So look at the other components of SAM, which may be a lecture by itself some other day. Next. So we start with one more slide before. We start with rehydration. If the child has no dehydration, we still give 5 to 10 ml of per kg of Resomal either with every vomitus or with loose stool. Which child has some dehydration, we start with 5 ml per kg of Resomal every 30 minutes in first 2 hours, and depending on the tolerance, we go up to 10 hours. Monitor the vitals every half hourly, especially look for signs of overhydration in the form whether he is becoming breathless. Look at the liver, whether the liver is increased more or not. So that is important because they suddenly will go into the cardiac failure and you will have problems. Next. So what is the in severe dehydration in SAM? What is the plan? So in this, the resuscitation fluid is 15 ml per kg of full strength ringer lactate with 5% dextrose to be given over 1 hour, may be repeated for additional 1 more hour, one more time, so that we give it over 2 hours, the 30 cc per kg. Monitor the rehydration and fluid overload and shift to the Resomal as early as possible. Next. So we start the child with a starter diet, which is 130 ml per kg every after 2 ORS feeds or 2 Resomal feeds. The third feed has to be of starter diet. Then again 2 feeds of Resomal and then the starter diet. For frequent vomiting or severe diarrhea, we can use the diluted F75 or lactose-free formula depending on the situation. If F75 is not available, there are F75. How to prepare F75 in the clinic is available. But if that is also not available, we can use thin rice moong dal paste with jaggery added to it. Okay. Next. The other management is routinely as of the SAM is supplementation of potassium, magnesium, and zinc as the protocol. Treat the infection empirically for 1 week with either ampligenta or ceftriaxone. This has a significant impact on reduction in the mortality. Give vitamin A and folic acid on the day 1, but iron after stabilization, that is after second week. Avoid standard ORS, avoid IV fluids as far as possible. And once the child is better, you start iron during this recovery phase along with shift to F100. Okay, next. Now this completes our second case scenario, that is severe acute malnutrition with Sam. Do I have the time to discuss hypernatremic dehydration?
Yes, madam. 10,
Okay,
10
Yes,
15 minutes you
yes.
can.
10 minutes, na? Okay, fine. So again, this is a hypernatremic dehydration, though more common in young infants. We do still see neonatal hypernatremic dehydration. I have really not dealt with today because the causes factors are different, the presentations are different. But here, diarrhea with hypernatremia in a little older children, maybe 3 months onwards, which we can really follow. So, what is hypernatremia? Hypernatremia is defined as serum sodium more than 150 milliequivalents per liter. So, then we classify them as mild hypernatremia, moderate, and severe hypernatremia, depending on whether sodium is between 150 to 160, 160 to 175, and more than 175. So it is common in infants who are top fed or who are with inadequate feeding practices. Usually, the along with diarrhea, they present with lethargy, irritability, high pitched cry. Actually, those who have heard the high pitched cry, they will know. And what we can see is eyeball. The eyeballs remain turgid. Means diarrhea usually they have sunken eyeballs, but in these children, though the eyeballs are sunken, they are very tough. Tough in the sense that you cannot rear, they are not flabby eyeballs. And they have a doughy skin, which gives rise to that rough feeling of a hypernatremia. I think if you experience it once, you will never miss it. So, whenever a child with this severe dehydration or you are suspecting electrolyte imbalances, we need to send serum electrolytes. So sodium and potassium chloride, these three go hand in hand, sugar and creatinine, to know whether kidneys are doing well or not. You need to monitor, once detected, you need to monitor the sodium and the sugar every 6 hours. Next. So what are the principles of management? So first and foremost, we need to correct the sodium very slowly. Like unlike hypoglycemia, where we give IV glucose and correct the hypoglycemia, if you really try to correct the sodium rapidly, you will cause more problems than the condition itself. So principle is correct the sodium very slowly over 48 hours. Avoid rapid fall because that rapid fall can cause cerebral edema. The oral rehydration is the preferred route, and standard WHO ORS is the preferred fluid which we would like to give. Use IV only if it is needed, and for rehydration, use standard WHO ORS for 48 hours, and monitor closely for neurological symptoms like fontanelle, and irritability, convulsions, and reflexes. Okay, next. So if IV rehydration is needed, like child is in shock or shock-like condition, and if IV rehydration is needed, you give 10 to 20 cc per kg of normal saline bolus slowly over 1 hour. And how do you correct? You in the correction phase, you use half DNS. You don't use normal saline. You use half DNS. How do we use it? So how do we calculate? Supposing if your serum sodium, child is asymptomatic, serum sodium of 160. So means in the sense that you continue feeding, you give him plan B of ORS or give ORS depending on the fluid calculation, and automatically it will get corrected. But if the child's serum sodium is say 175, 180, so we need to really treat it. So how do we need to treat it? We have to give a deficit fluid plus maintenance fluid over 48 hours. How to calculate deficit will be in the next slide. So give how do you correct? Supposing if the sodium is 175, we correct it up to 10 or maximum 12 milliequivalent. So our aim is to bring down 175 to 165, 165 to 155. So over 48 to 72 hours, you will correct this hypernatremia. So not more than 10 milliequivalents per liter in 24 hours. And look at the warning signs like drowsiness, seizures, and bradycardia. Next. So if a 10 kg child with acute gastroenteritis and serum sodium of 175, he comes to you, this is the clinical scenario. So our first day in 24 hours, our target serum sodium is say 165 milliequivalents per liter. Okay. So how do we calculate the deficit? Deficit is calculated, there are various ways, but I'm giving you the most practical and probably what I have been practicing. Is zero point 0.6 into weight into deficit. In this deficit, you will give observed serum sodium level divided by expected serum sodium level minus 1. So the deficit comes as 1240 ml. Okay, so this is our deficit calculation. And how much is the maintenance fluid required for 10 kg child is 100 ml per kg per day. So for 2 days is 2000 ml. So the total fluid to be given to the child in 48 hours is 3240 ml. That comes to 67.5 ml per hour. So the maintenance fluid, how are you going to use it? We are going to use half normal saline. Except for the loading which we will give in a shock where we had given normal saline as a bolus dose. Otherwise, we are going to use half DNS. And if the fluid restriction, child has a condition which warrants fluid restriction, then don't use half DNS, use only 5% dextrose. Okay, so you are going to use half DNS, 3240 ml of fluid with the rate of 67.5 ml per hour in an infusion pump. So this hypernatremia will get corrected over 48 hours. Continue feeding the child when child is taking. Don't give any extra salt. Give normal food. Don't restrict the salt also. Give normal food and which the child is eating. Okay. Next. So, any questions?
Can I say something, Alka ma'am?
Yes. Yes.
Ma'am, I have found that whenever we are doing correction for hypernatremia, then many a times these kids, because they are dehydrated, they also have a low bicarbonate
Yeah.
and an acidotic milieu, but the pH is normal. And people end up giving soda bicarb when we are correcting the, and that is the
Hypernatremia.
biggest problem that I face. It is very difficult to make everybody understand that you need not do anything for that correction, and it just takes you backseat on your, correction of hypernatremia. So that is a problem, a practical problem which comes up when you have more than one consultant who is, looking after the child.
And if you have to correct the acidosis, use ringer lactate because the lactate
Correct.
will have a sodium which is around 130 or lesser than that, and the lactate which around 30 milliequivalents, which will correct your acidosis.
Yeah. But at the same time, we have to remember that if the pH is maintained, then there is no need to give soda bicarb.
Body
There
is
is
good
just the
enough.
correct. So,
Yeah.
but it is, inevitably somebody gives soda bicarb and you are breaking your head as to why the sodium is not falling.
Oh, yeah, I know. I do agree. Definitely. So, really, thank you, IAP Palgar, for inviting me. And we are actually a part, Vaishali, for your information. This PG, for all of you, Vaishali was the one who has taken me, means who has actually closely associated with PGIMS, because she was away, she could not continue. So this PGIMS has been closely associated with IAP Palghar. And we are thankful to you for giving the opportunities. But next time we'll see to it that our residents present than we presenting. And today I got a
Thank
feel
you,
that
madam.
I'm presenting on rounds and Dr. Joshi sir is my teacher who's taking rounds on other side, diarrhea case. That's the feeling I got. Okay, fine. Yeah.
Thank you,
Thank
madam.
you.
Our next speaker is Dr. Raksha Tate, madam. Madam completed her MD DCH from Sion Hospital. Madam is practicing at Nala Sopara since last 35 years. Madam's special interest in childhood constipation, complementary feeding, and parental counseling. I would like to ask Dr. Raksha Madam to start her presentation. Raksha Madam, Tate
Yes, yeah,
Madam.
yeah.
Yes. Good evening, Madam.
Good evening. My slides are seen?
No, Madam.
Yeah,
Right. Yes. Just started.
yeah. Am I audible?
Yes, Madam. Yes.
Yeah.
Ma'am, can you make full screen slides full screen?
This is full screen now?
No,
Not
ma'am.
yet, ma'am.
Ma'am, go to the slideshow. Ma'am, right hand lower corner taskbar वर 61% लिहिलंय ना त्याच्या अलीकडे खाली
आता परत
lower most line on your screen where it is
Right
written
bottom.
61%, to the left of that there is a glass.
आता काही दिसत नाही कारण आता फक्त प्रेझेंटेशनच दिसत आहे.
अच्छा, आम्हाला अजून फुल स्क्रीन नाही दिसत आहे.
एक मिनिट मी ट्राय करते परत.
हा.
मॅम स्टॉप शेअरिंग करून जी फुल स्क्रीन आहे ना तीच परत एकदा रिशेअर करा.
आता शेअर करू.
हा, आता हे शेअरिंग आधी बंद करा. जस्ट अ मिनिट, आय स्टॉप शेअरिंग. जस्ट अ
ओके.
मिनिट. ओके, नाउ इट इज स्टॉप शेअरिंग.
हा,
यू कॅन रिशेअर अगेन.
आता रिशेअर करते.
या मॅम, अँड सिलेक्ट अ फुल स्क्रीन विंडो. येस, परफेक्ट मॅम. थँक यू.
ओके, या. ओके, या. पहिली स्लाइड नाही दिसत का? ओके, या. Good evening, everybody. आणि before I start, I would like to thank Palghar Academy of Pediatrics to allow me to share some information on retentive postures and withholding behaviors in constipated children. And thank you, Manohar, for kind introduction. Now, as title indicates, that we are going to talk about retentive postures, which is associated with childhood constipation. Now, we all know that we go by Rome 4 criteria to decide if any child is constipated or no. And most of the time, we get stuck to only stool history with reference to frequency and consistency and straining. But we do not go ahead of that. Now here we can see one of the criteria in Rome 4 about deciding if child is constipated or no is history of retentive posturing or excessive volitional stool retention. What exactly is retentive posturing or excessive volitional stool retention is we have not thought much about it, and not much is given anywhere in detail about this posturing. Now, as name suggests, retentive postures mean assuming such postures which retains something, which does not allow releasing something easily. Same is about withholding behaviors. And here, what we are talking about, what is something which is not released easily, is fecal matter in cases of constipation. Volitional retention of stools mean child is doing something voluntarily, at will. Nobody has taught him to do something and he is doing it on purpose. He has purpose of showing volitional stool retention because he wants to escape from undergoing pain when he passes motion. So he doesn't want to pass motion. He doesn't want to release motion. He wants to hold on to that. So what are actually different retentive postures which one may hear parents describing, and what exactly is volitional stool retention? We'll see in next few minutes. The purpose of choosing this aspect of constipation is because I felt that most of us do not understand much about what is retentive behavior and retentive postures. And most of the parents also are not aware of such postures being associated with constipation. So on their own, they do not reveal that their child passes motion in some atypical posture. If we ourselves, pediatric community, becomes more aware of such postures, then by default, awareness amongst family physicians and then society at large would surely become more aware of such postures, and they may volunteer sharing this information, and we will more often ask history of retentive postures when we suspect constipation in children. So hopefully by the end of this talk, it will be better understood that there are innumerable types of postures and behaviors to escape from pain at defecation. Let it be for some time only. To make this talk interesting, before going to list what are different postures, we will discuss two cases. First is a case of 2.5-year-old female child. She was brought by grandmother and father. Before asking anything, mother gave 4 points in history in one breath. She said child has fever for 2 days, but she has not been eating anything for 3 days. काहीही तोंडात घालत नाही, एक कण पण नाही was her sentence. But she has always been having poor appetite, पण आता तर त्याच्यापेक्षा पण खराब झाली आहे. She had not passed stools for 3 days and she was so cranky and irritable that they were finding it difficult to manage her at home, though she was stable when we saw her. She did not have cold, cough, vomiting, loose motions, abdominal pain, or urinary symptoms, rashes, anything. And all 5 other family members were normal, asymptomatic, did not have any other complaints. Now here, I'm not going to discuss about what could be the cause of fever or anything, because I'm going to talk about constipation aspect of this case. Clinical picture in this case surely suggested that she was constipated. What are the pointers to constipation? She always had poor appetite. She had not passed motion for 3 days and she was very cranky. So I asked grandmother about details of her stool pattern, and grandmother confidently said she passes stools once or twice a day and very easily, and her stools are absolutely normal and she is not constipated, and she could not see Bristol stool chart because she was not wearing glasses. Now, point to think here is from history is Constipation ruled out? No. Child may be constipated even if there is history of normal frequency of stool and normal consistency of stools. Now let's see. Suppose if we all come across cases where we suspect that particular child is constipated, but there is from stool pattern, we are not able to ascertain that this child is constipated or no. In that case, we should ask two questions. One question is regarding child's behavior when child wants to pass motion at present. And in older children, we should ask about past history of retentive posture anytime in the past. And second is history of complementary feeding. Now, when I asked this grandmother about what is child's behavior at the time of passing motion, that opened the Pandora's box, and she said, whenever she wants to pass motion, she lies down. ती लोळायला लागते. But this is happening only for last 4 months. So what was she doing before that when she was 26 months old? So before that, grandmother said she had habit of passing motion while standing. She says stressing that it is her habit. And 4 months ago, what had happened which made her pass motion into lying down position from standing position? She had one episode of passing very hard motion, and since then she developed habit of lying down whenever she wanted to pass motion. Grandmother relates both these positions as habit. She doesn't take it as some atypical behavior when she passes motion. Now, from passing motion from standing to lying down position indicates worsening and is severe constipation. Both postures enable child to tighten anal sphincter, so defecation can be avoided at least for some time. Like most families, even this family did not relate passing motion either in standing position or lying down to constipation. So the message is we need to ask about abnormal posture when child is passing motion. No one would talk about this. And second we learned is that even if there is probably normal stool pattern, child can still be constipated, and that also could be severe constipation. I said another question to ask to find out if child could be constipated or no is history of complementary feeding. This girl was consuming 1 liter cow milk per day till she was 2 years of age. This almost without any doubt endorses that this child has to be constipated irrespective of anything, and she was already started on complementary feeding when she was 3.5 months of age, and she was given thin khimti and ragi from 3.5 months of age. Now, from this history, we can be very sure that this child is constipated, irrespective of whatever reason for which child has been brought to us. Now, about second case. This is about 12 years old boy who was brought for abdominal pain for 3 years. Abdominal pain was on and off. Pain was more located to right hypochondriac region, epigastric and right lumbar region. He had already visited 2 family physicians many times, 1 pediatrician, 1 general surgeon and 1 adult gastroenterologist. He had already received cefixime, ofloxacin and metronidazole either singly or in combination multiple times, and antacids also multiple times. But there was no oral laxative any time on any paper, as probably no one ever suspected constipation. Maybe they did not even check previous prescriptions, and that was the reason same medicines were repeated again and again, or maybe they did not take their older papers to different doctors, or maybe most of the clinicians feel that antibiotic is panacea, and that is the reason child received repeated antibiotics, but without any benefit. He had bunch of pathology reports, all essentially normal. he had through 3 USG abdomen reports, which were normal, and 1 X-ray abdomen film without reporting. X-ray film was dated 2022, which showed fecal impaction. Father works at a hospital and he himself takes enema at home. So after seeing this X-ray, which showed fecal impaction, on his own, he gave lukewarm water enema to this 12-year-old boy at home. And after enema, this child passed stools like goat's droppings, which is like type 1 of Bristol stool type, which is very hard and difficult to pass. So now from X-ray and this history of passing hard stools, cause of abdominal pain was more or less confirmed that it is because of constipation. This is type 1 stool, which looks like goat's droppings. Now we come back to stool history here, that this boy's stool history was also not very significant, where he passes stools twice a day, type 4 followed by type 3 in one log, followed by little mucoid secretions. He always passes motion after coming from school and after dinner. He always rushes to washroom, that is holding behavior. And he does not use school washroom even if needed. That is also holding behavior, which is one of the causes of developing constipation in school-age children. See, this is the behavior which sometimes we come across when parents reveal such information. This boy keeps washroom door open because he is scared of ghost in washroom. So he comes out of washroom quickly. This is volitional retention, which is one of the criteria mentioned in Rome 4 criteria. Was it really ghost that child was scared of and that's why child was coming out early? Or was it child being afraid of pain at the time of defecation, which was making child come out quickly? Let us not discuss this because we will not have answer to that. Presently, this boy has very good appetite and he eats healthy food for last 3 years. But what about old habit? Before he developed abdominal pain, he was eating lot of junk food. And when repeatedly doctors told them to stop junk, they followed doctor's instructions. So suppose if we had taken diet history in this case and stool history alone, in that case, we would get misguided. And we may miss constipation in these cases. Though X-ray abdomen showed fecal impaction, there was only film and it was not reported. But even if it was reported, I feel that very less number of X-ray films are reported as suggestive of constipation. Now, even if in this case constipation is sure, but now I wanted to know approximate duration of constipation to understand severity of constipation. So that would help in treatment planning. So I asked direct question, at what age he had started passing motion in squatting position? And answer was spontaneous and they said around 3.5 years, 3.5 years. But what more they revealed was not only interesting, funny and sad, they volunteered information that their younger child, who is now 4.5 years old, also defecates standing. And they did not feel there was much big deal about it because they could never relate it to constipation and what constipation can do to that any child. All these parents need a lot of counseling. First counseling needed is to make them understand that retentive posture is child's efforts for not passing motion rather than efforts to pass motion. Because most parents associate retentive posture with child wanting to pass motion. It's child's efforts at passing motion rather than not passing motion. Second, they need to be warned that even if now they know that this deviation from normal posture is for preventing defecation, they should not forcibly make any child sit and pass motion. And if child is not willing to use washroom for passing motion, they should never force them to use washroom, as forcing and changing this pattern would aggravate constipation and affect them very badly. Now, let us go to enumerate what are different behaviors and different postures which parents describe when child is wanting to pass motion who are constipated. These behaviors vary as per age. First, we'll talk about infants. Do infants also get constipated? Yes. Can functional constipation present during infancy? Yes. Now, here we can see two pictures. One, child turns prone, and in other picture, child is arching back. And both these features enable child to tighten anal sphincter to prevent defecation. But this history also may be elicitable only if we ask. Now, we are familiar with child arching of back with gastroesophageal reflux, where some parents might be able to tell us that this is the way child behaves when child passes motion, and that should give alarm that it could be either gastroesophageal reflux or constipation. Now, when we go to little older children, out of numerous behaviors, the commonest is child becomes very quiet when child wants to pass motion, goes in one corner of the room, as if like child wants to tell us that do not disturb me, as if child is concentrating on something. Yes, child is concentrating on something when child goes in one corner and stands quietly, is concentrating on tightening his anal muscles so that he will not pass motion. Some other descriptions are child doesn't want to pass motion in front of anyone, not even family member. The way we saw that they want to lie down and pass motion. Some children go on running in whole house round and round before passing motion. All three features are very common when they don't want to pass motion. Is they go on their toes as seen in the first picture. They hold on to either table or some furniture, which is similar to going on toes. They take support of that furniture and tighten gluteal muscles. And third is they stand and pass motion. Some of them hide behind sofa, some hide behind curtains, some go cross-legged, some has their own method of restricting motion. There are large number of children who want diaper to pass motion, or they just do not want to get out of their diaper whole day also. And older children, 4, 5, 6 years also, they demand diaper and then only they pass motion, is very commonly elicited in history. Now, so many parents tell us, आमचा मुलगा मुलगी संडास आला तरीही धरून ठेवतो, दाबतो, वो दबा के रखता है संडास आएगा तभी. That is holding behavior. They do not respond to nature's call immediately. They do understand that they have urge to pass motion, but they do not want to go to washroom. For whatever reason, they are busy studying, busy playing, busy watching TV or anything, and they hold on. And they are restless at that time. They are very fidgety. Some of them rock back and forth and hold motion, and then they run to use washroom at last minute. This is holding behavior. Some parents say that my child does not allow cleaning after passing motion, or they are afraid because that cleaning causes pain if they have fissure. Some children go and sit in family member's lap. Some parents say that when child wants to pass motion, we can make out because child's face goes red, child flares nostrils. Some children make some weird sound when they want to pass motion. This is their, like, it's something like they're straining, and that is the reason they are making some sound. A large number of children would not like to pass motion inside washroom, and they refuse using washroom even at home. There are some children who use washroom at home but are not willing to use washroom anywhere outside, be it school or at tuitions or at friend's place or wherever. And this is holding behavior. Some say that my child holds on to the tap in washroom or water pipe in washroom, sits asymmetrically tilted, or sits and gets up, again sits and get up, or sits halfway, doesn't fully sit the way we should sit in squatting position. Another important aspect is how much time child spends in washroom. If child comes out of washroom very quickly, that is volitional stool retention, as we have seen earlier. If child comes out of washroom very quickly, even if your child is not constipated, but if this happens repeatedly, in that case, child will get constipated, if not constipated now. But when this is happening habitually, this is surely associated with constipation. Phobia with anything related to feces, whether we talk about feces, whether we talk about washroom, whether we talk about passing motion, whether we talk about flushing, anything. Fear with any talk related to potty or even smell, that aversion to fecal smell, fear of feces, all descriptions are related to childhood constipation. Now, little older children, those who have encopresis, some of them hide their underclothes which are soiled so that they would not be caught. Some do not even accept that the marks in underpants are related to soiling, and a small percentage deny having encopresis completely, where physically that child can see that there is feces in underpants and still there is denial. And these behaviors are also considered sort of associated with constipation, and this behavior is with withholding behavior. So to summarize, history of retentive postures and withholding behavior help in diagnosis of constipation, help in planning treatment of constipation. It also helps in monitoring response to treatment, as once treatment for constipation is started, our first milestone is that child's retentive behavior should change to normal, because unless child's retentive posture changes and child's attitude to come out of washroom quickly is improved, child can never be disimpacted when we give treatment, and we can understand prognosis of constipation to some extent, as in this second case of 12-year-old boy whose constipation was for more than a decade. This child is likely to have severe constipation. He will need aggressive treatment, and in such cases, even if we treat aggressively for very long period, then also relapses are anticipated. So in short, if any parents tell us that my child behaves like this when child wants to pass motion, or when my child behaves like this, we come to know that child is wanting to pass motion. Even if child does not express desire to pass motion, we come to know. Or any peculiar behavior associated with passing motion is by and large withholding behavior or retentive posture. It is very easy to say that passage of stools should be as easy and as smooth as in normal position as passing urine. Any deviation from this is associated with some health issue. But this fact, which should have been as easy to understand, the way as easy to say for all of us to understand, but unfortunately, it is not so easily understood by common people as well as by medical people. Thank you.
Hello, ma'am.
If you have
Can I
any
ask you?
question, like
Yeah,
except
yeah.
one question, that at what age child is expected to sit and defecate, there is no mention of it anywhere that exactly this is the cutoff. But by and large, by 4 years, all the children should be toilet trained and they should be using washroom and they should sit and defecate, be it commode or Indian toilet. But what about 2 years, 2.5 years, 3 years is not mentioned anywhere.
Can I ask one question, ma'am?
Yeah.
Ma'am, we come across a lot of bladder bowel dysfunction. So we deal with constipation. Your lecture was very enlightening. Thank you so much. I wanted to ask you whether you show Bristol stool chart during history taking to parents.
It is there on my table for last 15 years. Before that, I never had.
Yeah. So, do you find that all parents are able to answer it properly? Sometimes I get very weird responses.
Most of the children who are using commode, they find it difficult to answer.
Huh.
But majority children who are using Indian toilet are able to answer. But there are few, like if you come across type 4 stool,
Okay.
make it sure to ask them, is it type 4 or it is a mixture of type 3 and type 4 together, that initially it is type 3 followed by type 4, then large number of them will tell that initially it is type 3 followed by type 4. But there are children who are not able to exactly define which type they have.
Okay. And the other question was, ma'am, that this girl child that you spoke about, what did you do for her? Means treatment wise.
I will share slide again and I'll tell you.
Thank you, ma'am.
The girl you are asking about was seen on 3rd July.
Okay.
So far, I have seen her thrice. Coincidentally, this girl's father, who is now 26 years, was under my treatment when he was small. So they were familiar with me. We gave her enema. Both these children got enema because their constipation was very severe. Suppose if you give oral laxative to these children, there is very high chance of their abdominal pain worsening and there is very high chance of them developing incontinence. Because there is impaction, you can imagine that there is something like that rectum is impacted with feces, and when we give oral laxative, we are not going to give high dose to begin with. We are going to step up step by step. So this cranky child will never respond. And after giving enema, this child passed very large quantity of type 1 stools like goat's droppings for 2 days. Within 5 minutes after passing stools, child started playing, demanded food. She was like an angel, like grandmother when she came for follow-up. that we did not know like where she is whole day. Her appetite is slightly better, but still not satisfactory when she had come for the second time. This child was on comfort breastfeeding when she came, though mother was not getting milk at all. Now this girl has stopped defecating in lying down position and she stands and passes motion. We had given enema only for 3 days to begin with, but when she came for follow-up, we restarted enema. This girl used to pass urine also in standing position, and now she has started sitting and passing urine. And she uses washroom for both number 1 and number 2 as words used by grandmother. And father also said same thing. And she has stopped passing urine, bedwetting, daytime bedwetting, which was a regular feature, was her own observation. And so far they are very happy, though constipation part is still severe because she is still standing and passing motion, and no child who is passing motion in standing position posture can ever have complete evacuation. But psychologically, once their fear is lessened, they may start sitting and defecating. We tell them that you just tell them once a day that you should sit and pass motion, but don't force. Don't tell when child is passing motion. Anytime in whole day you will tell them. And this is about a boy who was seen on 16th July and is expected to come today. When child was received enema for more than 4 days, then he started passing large amount of very foul stools and pellets, and that ghost has disappeared. Now he closes washroom. But it took more than 5 days for enema also to start acting, and we had given 2 enemas together, not one. And still there was no response. Next day also we gave 2 enemas, there was no response. And then again we made 1 enema in the morning and 1 enema at the night, but no response. Now he has started passing motion every day, still passing pellets. His abdominal pain kept on fluctuating and then went to suprapubic, and now there is no pain. But yesterday he passed some blood. So I will come to know how much blood was there when he comes today. And on their own, they have started giving enema to their younger child for last 3 days. This is what they messaged.
Okay, ma'am. Thank you.
Thank you, madam. It was a very nice session
Thank you.
regarding constipation. Very well said. What is retention? What is the posture? How we can diagnose by history. History is very important for that constipation. The first case was very interesting. The child was seen by pediatrician, gastroenterologist, pediatric surgeon, and finally that turned out to be constipation plain. Thank you. Anyone else? Any questions?
In this session, we are so fortunate to have 2 friends speaking on 2 different topics. One speaks on diarrhea and my other friend speaks on constipation. Such a wonderful GI coincidence. Okay,
Yeah.
thank you, Raksha, for such a wonderful lecture.
Thank
Two
you, Alika.
extremes.
Yeah.
Two extremes.
And one is regarding kidney.
But I should congratulate you all. You all have such good attendance. Everywhere else, clinical meetings are doing so badly, and nobody wants to attend, nobody wants to present, and Palghar Academy of Pediatrics is going strong.
It is all because of you people and Joshi madam, Joshi sir,
We are
madam.
occasional people, but otherwise, consistently the meeting happens. So keep going.
Palwankar madam is there. Deshi Deshpande
Yeah.
madam is there.
No,
I
the
will-
entire